Welcome to today's talk. It is my pleasure to introduce to you Dr. Genevieve Melton-Meaux, or in local parlance, Meaux. I have a tough time pronouncing French words, not French, but so I didn't know that there was going to be so much competition for introducing Genevieve. But there was. So last night I suggested to Chris, Brian, that we should form an ad hoc a cappella group to introduce her with song. Chris didn't go for that. When I refreshed my memory about Genevieve's many accomplishments, I thought this morning, you know, she has every single title known to man in academia. If I even briefly summarized her many accomplishments, it would exceed the available time for this talk, so I'm not going to do that. Suffice it to say, she is a colorectal surgeon. She is a very accomplished health informatician. She has an operational role at Fairview Health Systems, making strategic decisions about AI and technology. And last but not least, she's also very active in learning health systems, which I understand is one of her foci today. So when I asked Genevieve how she would like to be introduced, she very simply said, well, just tell them I'm a nice person. I said, that is underselling you. What fascinates me about Genevieve is that she manages to package high accomplishment, high intelligence, high motivation, great leadership into this very modest and approachable person. And this is why we love her so much in multiple roles, including as president of the American Medical Informatics Association. And with that, I know I've prattled on too long. I give you Dr. Genevieve Melton-Meaux.
Thanks so much, Titus. Can you all hear me okay? Okay, I'm going to try this mic, and if we need to, we can switch off. So Titus, thank you. Thank you to Rachel and the rest of the Regenstrief leadership, Brian, and all the people that I've been able to meet so far in my visit. And also, this is an ongoing relationship. I have great admiration for the work that's done here and really appreciate the opportunity to visit with you. I'm going to talk about learning health systems, which excited to do this to start off your year. Excited to be here. I felt like I was just coming home, coming from Minnesota, and I'm going to talk to you about our experience, where we're at. I like to say we're a toddler now. We're not an infant anymore. We're beyond crawling, but we might be running around a little bit like a toddler is, okay, as a learning health system. I have no disclosures. I'll start there, but I will be talking about some software products along the way, health IT products along the way, and I am not endorsing any one of them, so I'll just mention that up front. This talk is going to focus on learning health systems as a whole, talk a bit about how really this is a role, or sorry, learning health systems have a really important enabling piece, I think, in how care is going to be transformed over time. And I will talk a little bit about digital transformation in that. And then finally end on really the people piece, training and the ability to have a workforce that can do this work. And we here, as a group of health services researchers, informaticians, and folks that are focused on aging, I think Regenstrief has a huge role in that. So who are you talking to? I put this here because I know that we do have a lot of learners that are here. And I think the point is your route doesn't have to be linear, okay? Mine has been very circuitous over time. And where you start is not necessarily where you will end up. I like to say that I'm on my 4th avatar right now. I started as a computer scientist, went to medical school after doing cooperative education, and I really thought that, you know, I need to never be behind a cubicle doing data, computer work again, and look where I ended up. Along the way, and I will talk about our origin story, I was doing health operational work. I was running value-based care for our health system, and I had this very interesting role as our Chief Analytics and Care Innovation Officer. And really, I'll talk to you a bit about learning health systems in this next avatar. So I'm going to start with the why, because I think more than anything, that's what motivates this. Okay, why do we need a learning health system? It's really this failure to translate. And that dripping faucet is truly what's happening. What actually gets to patients and how that gets into healthcare. And I will submit, we don't talk enough about the policy piece. That's a huge component as well. And I know that rings true here. But we have so much that we learn, and getting it to where it actually matters doesn't happen enough. Just another thing to reinforce that, we spend so much in evidence-based treatment, all this research, we don't get it into care, and we have historically underinvested. I mean, look at what's happening with AHRQ and the relative lack of funding and how much health systems go, but don't learn along the way or bring that evidence into care. So one solution or one really important enabler in that is a learning health system. This is one definition that AHRQ has brought. This has really been an impetus with the National Academy of Medicine, IOM, and others. And you know that things are changing when you see we have genomics enabled learning health systems and other calls that are really bringing this into something that's real, okay? So there's many opportunities here, but what I like to say is that a learning health system is building a different animal, okay? We're taking the best of healthcare delivery and patient care and patient health, and we're bringing that together with the best of research. And it's that in-between practical, pragmatic, and we have to build something different on both sides and bridge those gaps, okay? I'm going to take a quick detour, but it's very related. We're in the middle of, a true transformation in healthcare, and a lot of it is digitally enabled right now, okay? And I would submit that as many of us being informaticians here, we've been in the middle of this. Everybody's talking about AI, but it really is much more of a digital health disruption and transformation that we are undergoing. A lot of people talk about digital and, what is it? SmackStack is one of those analogies that we talk about. We have dubbed it a little bit different, social mobile instead of analytics, AI and automation, cloud and knowledge being the analytics, but just a way to think about how our lives are changing to be fundamentally very digitally enabled. Think about retail and what it looked like 5 years ago or 10 years ago compared to now. Think about all the ways that digital technology is really moving into all our lives, and healthcare is part and parcel. And to deliver that well, we have to think about all the pieces that go along with that. Think about how we have done health information technology with the electronic health record and how some things have worked and we've done some things pretty badly as well. And so we have to learn and we have to build and we have to be able to scale within healthcare. Okay, so then I'm going to focus on our origin story. It's one of several, but this is ours in Minnesota. We were very fortunate to have our chair of health policy management when the first K-12 scholar program was initiated, was able to garner a training grant in learning health systems. In 2019, we also founded a joint clinical enterprise with Fairview, Health Fairview. And really just, that was a huge impetus to become a system, think about service lines, how we deliver care in a consistent manner. And then we went on this trip. I mean, the date, my gosh, how apropos, right? So our chief academic officer first, our chief quality officer, myself, also in somewhat of a bridging role, and then Tim Beebe, who is my partner in crime in health policy management through the School of Public Health. And then we were having investments in digital transformation, and oh my gosh, the last ingredient of all, COVID. But really, I don't know where we would be right now if we didn't have all those ingredients, because all of these things influenced how we got to where we are right now. So thinking about our health system, just one example, this is a program that I've run operationally and still have a leadership role in, which is our CareMap program. Really the idea of delivering evidence-based care in a consistent manner throughout our health system, enabling it with not just the protocols, but the health IT underneath it, the operational pieces, the patient education, sometimes with digital work, and putting innovation within it. And this has been a huge scaffolding that we've been able to use for this particular health system that we've worked with. This gives you kind of an example of some of the care maps that we've built. We call them care maps, but it's just a way that we have sort of labeled, and we have a common language to talk about it. But it could be, I don't know, evidence-based care, you could have a different name for it. But this just gives you sort of an idea of some of the work going across the continuum, thinking about how we care for people, in all different settings, and do it in a consistent way. So the center that we formed really is now about 3 years old. I think some things that are a little bit unique about it are that it is a true partnership between the School of Public Health and the medical school. We also have several members that are outside of those two entities, so it's truly interdisciplinary, but those were the first two entities that invested in us. This kind of gives you sort of a schematic of our different parts. I'll walk through them, so don't feel like you have to memorize it. We'll also make these available as well. A couple things to note. One is that there's a huge sort of data component, but also a huge piece around implementation science and evidence. And I don't know if in all cases, depending upon your vantage point coming to learning health systems, if all of those pieces are looked at, and I'm sure we're missing some as well. So I want to acknowledge that. One piece that we've been talking a bit about is sort of the idea of education of the workforce, more around the idea of learning and bringing those learnings back. And that's some of the D&I work, but there's probably a little bit more there. Another thing to note when you look at our leaders is we tend to use more of a dyadic model in most cases for most of our units and programs. And often it's a clinical person as well as somebody that's a subject matter expert more from a PhD perspective. Okay, so I'm going to talk a little bit about evidence synthesis to start. This really was built off of our work with the Evidence Practice Center, which is an ARC-funded center that's been around for the last over 25 years. And what we really have built together is a little bit beyond what you think of with a traditional evidence practice center, but really this idea of a more agile, practice-ready resource and core that can be available to health systems. They've done work now not only with Health Fairview, which I focus on a bit here, but also with several of the other health systems in our state. And they've now served our Minnesota EHR consortium, and we have them as sort of a centerpiece for what we've been thinking about for a statewide cooperative extension center. So just to give some examples of some of the work that we've done around evidence assessments for the health system. And in addition, we have now 3 evidence communities that we've been building. And this is just an example. It happens to be, of course, in my division, but really this idea of bringing learners, in some cases being able to do task orders, but also be able to have this be sort of a buttressing for evidence that can be done with learners to be able to just advance the science. Not necessarily always getting funding, but really bringing together folks in a little bit of a different way. So most of the folks that are pictured here are actually residents. Paolo Goffredo and Wolfgang Gertner are 2 faculty in our division. And then Mary Butler leads the Evidence Practice Center, and then Bronwyn is her dyad as the clinician or the subject matter expert. This is an example of a grant that we obtained through the FDA both to start to not just build a systematic review and a national guideline, but then bringing things to more of a dissemination and evaluation stage. In addition, this idea of a living guideline is one that we are really doubling down on, especially now with AI being an important component. We do have a connection with Indiana on this particular interoperable decision support grant. And that's been a lot of fun to have several centers that were doing this work. Okay, so I'm going to talk now a little bit about our pragmatic trial unit. We affectionately call it Rapid Eval. And just for folks that maybe haven't been exposed as much to the idea of pragmatic trials. Oh, and I do have a picture of Mike Usher, who, if you don't know him, you need to know him, and you guys need to have him engaged. And Mike originally, along with Joe Koopmeiners, who is the head of biostatistics, were the original dyad for this work. And Debbie Pesca, who's an implementation scientist and a pharmacist, is now the dyad. But Mike, I give him so much credit for a lot of the work that we've been doing. Okay, so for folks that maybe haven't been exposed as much to pragmatic trials, really, again, it's this idea of bridging, right? So quality improvement, a lot of work that gets done, often in a less rigorous way. Nothing wrong with it, but we don't always know, does something actually work, and why does it work, and or not work? And then, clinical research, which is definitely important, but very, very controlled and limited, and not necessarily real world. And this idea of bringing things together in a pragmatic way and building off of real world evidence. And so we founded a program called Rapid Eval. And what we do is we have a call for applications. It is meant to be very democratized. We have folks that have applied that have gotten this. Shauna was a pharmacy resident. Sagar was a surgery resident. Most of the other folks are actually faculty, but we've definitely had applicants that are operational folks, and they always have the support of operations as part of it. So we do a call for proposal. Why is this important? How can this be done truly rapidly? Are you at a stage where you might be actually ready to do something to test something that's important meaningfully? We tried very hard, and as part of sort of judging these, we have folks from operations that are part of this to be sure that this is important to the health system and that they're going to have the right support behind it. And so far, we've had 12 different pragmatic trials that have been implemented. We've had 5 calls for proposals, and we've had over 60 applications. So it's been, this I would say is one of those examples where we've been able to start really building an apparatus and a set of capabilities around this. This has helped us be competitive for pragmatic trials more broadly. And this has even garnered, I told Rachel this morning, our CEO said, of the health system said, hey, I want to know if, appointment reminders, what's the optimal way to do this? Can we do A/B testing? So it's an example of a rapid eval that the CEO initiated, as a for instance. This has also created lots of opportunities and learnings about how to support these trials from a health IT and informatics perspective. So we've shared some of those findings here. It's really important to note, and I only have one slide on this, but for each of those trials, in almost every case, actually every case, maybe with the exception of the A/B testing, and we did some qualitative work with that and just test in trying to get patient testing up front. But in almost all cases, we do qualitative work after we've implemented as well, right? To try to understand what worked, what didn't, what can we do differently? And having that apparatus is quite important as well, and probably is underemphasized as you look at most of these initiatives. Okay, I'm going to switch and just shift a bit over to some of the informatics components around data technology, et cetera. So we have a unit that has been focused on digital technology as a whole. We really have tried to focus on the different components around the experience, the technology, the operational pieces as well. And we think about this in terms of product development, something that is going to be managed on an ongoing basis versus a project which is quite time limited. And I'll give a couple of examples. So this is an example of an idea that came from two faculty, Mike Pitt and John Sartori. John is EE, Mike is a pediatrician, hospitalist pediatrician. And his idea was, let's build a digital product that is going to create transparent rounding. And so Q rounds was what came out of it, and I'll just kind of go through it. So this idea of if you're a family member, if you are the nurse at the bedside, or some of the other staff or providers that are taking care of a patient, having transparency around when the patient is going to be seen, and how to create expectations around that is what this product is trying to solve. So Q rounds is integrated into the EHR. We did a lot of work with IT to build this out and to evaluate it. As you can see, it's a mobile app. This is an example of what the patient or their family would see. We started this in the NICU. This has now gone to the PICU, and we finally have this now in the adult setting. But finally, the idea is that everybody's there when it is timed around and folks know what to expect. And you can even do a virtual, have virtual members of the team as well. So if family member's not physically there, they can be virtually there. This is integrated now into Voicera as well, so the nurses know as well and can continue to do their work as they go. We've integrated interpreter services. It's integrated as well into the EHR. If somebody happens to be physically there and has the chart open or has a patient list open, they can see that. So far has had great engagement. There are some pain points in there because folks are not always used to it being that way, providers and nurses alike. But as a whole, very, very positive. Some of these features are now in place. This family queue is now in place. The desktop rounding is not yet. And just an example of some of the dissemination this past year. This is a different example. This is now a pragmatic trial that we did a lot of usability testing around, but the idea here is the idea of to help avoid, and Chris, you'll like this, help avoid having opioid misuse. The idea of doing behavioral health interventions or behavioral economic interventions directly with the patient to promote weaning, promote less use of narcotics along the way. So we have two behavioral economic interventions that we're testing right now at two of the ambulatory care centers. Again, this is the birth child of Sagar, who is a surgery resident right now. This is an example of a OBGYN faculty who had started several years ago, but relatively junior OBGYN faculty who has developed a maternal hypertension program and built a digital solution that's integrated into Epic, which started now at our University Health Center, and over this year we'll be expanding it to the rest of the system, but has had a decrease in readmission of over 70% in this higher risk population. And then finally, an example of a grant that we have built using system engineering. And if folks maybe are familiar with some of AHRQ's patient safety learning labs, but this idea of how do we build digital solutions around the recovery period at home, and really take a patient-centered and qualitative perspective up front to learn. And this has been a lot of fun from the perspective of it's not often that you get to take a problem and take it from beginning to end and try to almost naively go to the situation and try to learn from the folks that are doing that are actually being affected directly by this. Okay, So as part of this, we realized that having better, more agile data services was going to be really important. And so C code was really the core that developed as a result. And we work hand in hand with our clinical translational science institute, but really have been building out a data platform that all investigators can take advantage of. And really the idea of how do we just continue to build out multimodal data, really engage our subject matter experts. And as a result, what has happened is we've been able to really build out our infrastructure. And it creates an ability for our investigators in many cases to be able to get data much quicker. I think, of course, really important, this hits home here, is the idea of being able to have really good data interoperability. So we do have a lab that is tightly affiliated with and within the Center for Learning Health System Sciences that has been really focused on building out the data resources in an interoperable fashion. Piper Rinaldo has been responsible for almost all the OMAP mappings that have been done on behalf of the Minnesota EHR Consortium, our OMAP instance. And we've been able to really make this so that we're thinking hopefully more systematically as we build out our data resources to be interoperable and smart in that. I'll give an example later of some of the work that we're doing with interoperability with machine learning, but we had that other example with fire-related resources for our interoperable decision support. I will say that standards are incredibly important. They're not necessarily prime time, so we can have a longer discussion about that. So just to give you an example, our approach in creating data resources for folks is to try to be a little bit more concierge for that clinician investigator that's coming to us, right? So the typical thing that might happen is somebody has an idea, they may have to go get their IRB, they may have to do some work around the data management, et cetera. And I don't know why I don't have the IRB on here, but that's actually an important point. They come to us, we help them do their IRB. In most cases, we can get that approved actually very quickly, within a week or so. And then we're able to get them the data and deliver it. Not in all cases, but we've built things out in a pretty systematic way. And we've had it's close to 28 folks that have helped us to build out the data resources. So part of the responsibility is when Randy Lassiter comes to us as a pediatric surgeon and says, I want to build XYZ out, and it's a new set of variables, she's going to be part of the solution to help us build out those variables so that the next person who comes can take advantage of that, and we have better data for the pediatric population. And then I'll just mention as well, two programs that are really interrelated, one around AI directly into healthcare. We call that our P4AI program. And then the other really trying to build out, I would say it's more of a hub and spoke model of being able to build connections with folks that can work with us and work with investigators to build out data science services. Now we have a university-wide data science initiative, but on the health side, we really want to be a good bridge to folks. So, we have folks that do computer vision. Most of them sit in computer science and engineering. And we've really sort of leveraged the connection with the Institute for Health Informatics, biostatistics and health data science. And Julian is from there, as well as others, to try to just get the right expertise to be able to help solve problems for investigators. We've also had to work very closely with the folks that handle our HIPAA compliant environment. Still are working with our Minnesota Supercomputing Institute to get to something that's truly HIPAA compliant for what clinical investigators are going to need from having PHI, but we're well on our way. We also have really tried to leverage cloud services as much as possible, as much as we can afford. So that's another discussion that we could have. And then the other thing to mention is collaborations, particularly around federated learning. I think more and more, just to be practical, in many cases, that's an approach that we are taking. I'll give an example of that. And this is one that Indiana has been collaborating with us. So this is an example with rib fracture. Oh, and the point here is that you want to be on the other side of the graph, and this is where we started. And we've moved a little bit over midway, but we had a lot of variation, and we were not doing guideline concordant care. And a big piece there was not recognizing the number of rib fractures, and then beyond that, not delivering the right evidence-based care. So again, pulling together folks from an interdisciplinary perspective, trauma surgeons, radiologists, and the data scientists. Our hope is to be able to do truly, a set of pragmatic trials across multiple opportunistic points in time where it maybe makes a difference. Right now, it's really around the diagnostic algorithm and then pushing the right evidence-based care. Okay, I'm going to skip a little bit. This is an example of some work that we've been doing with University of Florida. And there is something called My Surgical Risk, which is an AI algorithm that's actually, I think, 8 or 9 algorithms to predict what might happen to somebody after surgery. And we can help advise patients better on what to expect after surgery, maybe things to help optimize a patient that might get surgery, or maybe they don't need surgery, right? Maybe something else is more appropriate to be able to triage these patients. So just to note that this is a really good example from the Program for Clinical AI in just trying to, number one, externally validate something, using something that is interoperable and finding out like how different implementations can be and how data mappings are not as simple as you might think. So we've been working on this. Our validations show that we actually made very different decisions along the way. And we can talk about who made the right decisions as far as data mappings, but we came out with different answers, and it doesn't validate exactly one-to-one. You have to do some retraining to make it work well. So interoperability is an important part of our future, but there's a lot of work, really important work, that informaticians can be a part of. I'd be excited to talk to you more about some of these other projects. Jill, I thought I'd mention that we just became a part of AIM Ahead. So we're excited to embark on that. And then finally, this is about to go into ARPA-H. And if any of you saw the Precise AI, it's one of several programs that they have out there that are very informatics, data-centric. And this will go in this next week. We received encouraged to submit the full proposal, but Indiana is one of the sites that we'll be working with, we hope. And this will look at both My Surgical Risk as well as an FDA-validated algorithm around pneumothorax. But the idea is to be able to do really better monitoring, self-adaptation of AI, and really think about how to make it more, make AI and decision support more user-centric, and even having interactive AI. So hopefully a lot of fun that we'll be having. Okay, so really to close things out, I wanted to talk a bit about our Learning Health System Scholar Program, which again started as our K-12 training program and now has become the P30. And AHRQ PCORI, I think, changed the mechanism in large part from the feedback that many of the sites had with this first iteration. And many of the sites were saying, you know, it's great that you're funding scholars, but in many cases, more infrastructure is needed, more flexibility is needed. So they changed the mechanism to a P30 with the idea that this is really still about training, but you can build some infrastructure in the process. And the things that have changed are really additional health systems, covering more of the state. And our hope is really that this will help us as a state really rise all boats, have greater collaboration, and really improve the health of our state. It always helps to see faces and names, but just to give, even just a little bit more color around this, we had 14 scholars over 6 cohorts over the first 5, and we extended out to 6 years. We were very fortunate to get some bridging funding. I think a total of 4 or 5 of the scholars were funded in addition through matching funds from the university and from our health systems. And then the P30 program really does expand on it. So we have the traditional scholars. So Rubina Risby and Melissa Harry are examples of the scholars. They're independent scientists that are early in their career, that are having career advancement. But now we have what we call our fellows, which include some pre-doctoral, but mostly postdoctoral trainees. So residents, some of the VA scholars, our clinical informatics fellows are also participating as fellows through this program if they choose. But the idea that they would have, an individual development plan, mentorship, a community that they can work with, and be able to gain additional skills and resources in their work. At the end of the day, it really is about building out this community. I hope that I'll be able to tell you that soon we're going to build out a learning health system accelerator. And the idea behind that will be to help other health systems be able to come with somebody that wants to lead a learning health system set of work, a bridger with a health system, and be able to help share tools for other systems to be able to do this. Chris, thank you for being our first inaugural seminar speaker. And with that, thank you so much for the time. I'd be excited to take questions.
Thank you, Genevieve, for a great talk. Questions from the audience? Andrew.
Hi, thank you so much for coming. I'm Andrew Gonzalez, one of the vascular surgeons here, and keeping the fingers crossed for the Consort AI, or the Predict AI grant. You had a slide up about the data interoperability and how you're sort of building teams out from that. So I was wondering, at your institutions and others that you've seen, what is the model for payment? At some places, to get your data, you submit to some type of data core and the investigator pays. At other places, they're like, wait, you're paying for data on the patients that you saw in your own clinic. So how does that work at your institution? What do you think is the best model, and how does it work across data types like radiology, intraoperative video, EHR? Thanks.
Great question. So just a couple comments there. Data access is the first part. The other part that is coming up more and more is some of the computational pieces. And you mentioned the AI component, and that can be quite expensive. So I won't even deal with that yet. Okay. And the answer to your question is it depends. It depends on who you go to. Our model is to try to really have sort of a balanced portfolio with the idea of those that should pay the expense that it takes and the effort that it takes. If somebody needs it, we have a couple of different sources that folks can get data. And if they truly can't afford it, in many cases, if we're able to, we do. And we keep track of that. We've been very, very diligent in keeping track of that and trying to understand our reach. I mean, we do want to get the investigators that are going to build great research portfolios, but we also want to get the investigators who just want to do their study and be able to have a way to disseminate. And we have an ISO at this point as well. So we have all the structural things. We have an ISO, ESO, internal services organization, external services organization, where we will do either truly like hourly billing as well as, a statement of work as well. So we've tried to cover those pieces. And then we have certain deals. We have certain arrangements with certain departments. So up to a certain point of capacity, several of the departments have bought out enough time and enough effort that we support actually almost everything, or if not everything, that is asked.
Other questions, Brian?
Yeah, thanks. I wanted to ask a question about going back to the examples that you gave of the Q rounding and even the project that's in your own division. Like for the Learning Health Systems Center, like what's I guess the strategy and process for determining, oh, this is going to be we're going to support this idea of Q rounding, right? Because it had to start somewhere, and so is that something where you all provide like pilot funding to get it going, and then they go after external grants? Do they go after an external grant and just partner with your center for the project? Sort of what's the model there to do projects under the umbrella of the Learning Health Systems Initiative?
Again, I think the answer ends up being a balanced portfolio and trying to, I think one of the things, I mentioned we're like the toddler running around. One of the things that we are really trying to have our eye on is true program management of our resources, being sure that we truly understand our capacity and can really do the things that we've promised to do, or if we need more staff to really understand what we can afford and what we can do. So I'll just caveat with that being said. But in general, we would love to get, in most cases, to something like what we have with Rapid Eval. And we have examples of, we are looking for projects in ADP around digital technology or clinical AI. But many of the things do come in other ways. So grants are a great example. If we understand early and we understand what we're planning for, it makes a huge difference, right? If we get it after the fact and it hasn't been scoped correctly, we have to figure out what the gap is. So there's a lot of examples like that. And certainly, if we try as much as possible to ask for, we have a service request where if folks want to ask for a request, whether it's even pre-award stuff, non-award stuff, an idea that they'd have, we will do consultative services with them. But again, I think as much as we can stage gate it, we have found that to be helpful, but it's that balance between people come as they are and encouraging the creativity and the innovation. We want to have that, but also set clear expectations. So a very long answer and not an absolute clear one, but I think it's the issue of healthcare operations, IT life, et cetera. Yeah.
I think you'll notice a trend. It's like the third question you're going to get about funding. So I guess I was in particular, curious about the embedded pragmatic trials and sort of how they're covered. And some of it is about sort of people's time and then getting the partners, so because one of the big rubs is that many of us are, independent investigators who have our time fully committed. People who work in the health system have day jobs. And, there really isn't an easy mechanism to kind of carve out actual effort for people to kind of work on the project, even if you are able to identify the right people to implement the project. So I'm curious about the process for that.
Yeah, so a couple different pieces. One is that for the person who brings that idea, we do set a set of expectations with them. And that has, for the most part, been pretty successful. But, people are busy and that can be hard. I think the other things that have helped quite a bit are we have staff that are actually hired that sit physically within the health system. So that does help as well. We have medical directors, and you saw the dyadic model. We pay for folks to spend their time dedicated to that. And Joe Koopmeiners, who's the head of biostatistics, yes, he does a lot of work with us, but there is also statistical staff that are supporting. So I think all those pieces are really important. And I think the other big part has been having a scaffolding wherever possible. So it's a much smaller lift to do a small innovation or an innovation, I shouldn't say small innovation, to do an innovation within something that's already part of clinical practice, and you're doing that change that's a lot easier and aligned with the work that's going on, as compared to something that's completely de novo and we have to shop around, that type of thing. So I think we've been fortunate in how we have chosen. And I do think the other part is we've been given some in-kind support. We've had a lot of support from the dean. We have support working directly with the health system, presenting at board meetings. And it doesn't mean it's always easy, because it's still research, right? And we've had even growing pains with, okay, now the trial's over. We've de-implemented a couple things. We've implemented fully other things, and really having a deliberate conversation. But money's a big piece, and resources that are directly in the system. I don't think it would have been successful without that.
Hi, so welcome. I'm David Hagstrom, Director of our Center for Health Services Research. So I think these are some great discussions. Maybe they'll continue about how one can best partner with an academic health center system. I was going to go ask a question kind of across systems. I saw in some of your diagrams, or the P30, I believe, that it seemed like there was a cross-system approach that both the university health system, but also Hennepin, the safety net, the VA, were all a part of that. And so I was just interested if you could speak some to governance around that, or what challenges that might present, or what opportunities bringing across systems and a learning health system model may introduce.
Yeah, thank you, David. So a couple comments. The training program is now across all those health systems. So Essentia, which is based up in Duluth, the Hennepin Healthcare, which is our safety net hospital, as you said, and the Minneapolis VA, and now Health Partners. So that has felt pretty easy, because what we do is we create this community of practice. We have folks come together. We have these things called design shops, where a scholar can come present their work, get input from all sorts of folks, right? Other trainees, faculty, and really learn about things like hidden curriculum, right? I mean, what's going on in the health system that you really don't understand, and why am I being told one thing and why isn't this as effective as it should be? So that part has been easy. What the P30, I think, is helping us do, and we have what we had pretty established already, was Hennepin Healthcare has a research institute that's very integrated into their healthcare system. So we've really leveraged that. And the Minneapolis VA as well has a research institute, and now Health Partners does as well. So we try to use the infrastructure that's already there and help build just additional bridges. I think the part that we are seeing is that more needs to be done. I don't have even a better way of saying it, right? So what would it look like if nurses, or say nurse managers on various floors, were engaged in this work day to day? So we talked about, the scholars and the fellows are great, but what would it look like to take a nurse manager for 6 months and have them be our fellow and then go back, right? Because what we want to do is infect them, right? No, we want to really make it truly embedded and create something that's different, and everybody hopefully can see the importance of it. Because right now there's I think in many cases there's a lot of friction, right? So the more we can sort of remove that friction is important. I'm hoping, we talked about the statewide extension center and the idea behind that, and hopefully Indiana has applied as a state, but it's to create a statewide evidence collaborative. Now, it's supposed to be starting in behavioral health, but the idea is that you could do it for other things to help improve the health of the population of the state. So I'm hoping that that will be also a catalyst. That is going in right now.
Oh, do you want to do online one question? Okay. Thank you. I have a lot of questions, but
Oh, no.
I'm going to stick with one and not the funding question. I'm curious about the the overall or goal for the center, your center for learning health science or system sciences.
Mhm.
And, do you have an annual goal or a 5-year goal? And is that related to impact? Is it set, are those goals, assuming that you have them, are they set with the health systems? And if so, how frequently? Or is it set more with the School of Medicine? Just trying to think a little bit more about, are these the traditional types of goals you have that in an academic system like grants and publications versus impact or, delivering more cost efficient, affordable healthcare, for example. So wondered if you could speak a little bit about goals.
No, I'd love to do that. So one comment is that we were first funded for 3 years with a lot of, well, primarily seed money from the medical school and some from the School of Public Health. And we've been fortunate to get refunded. And now with more external funding, that has helped us as well. So all those things are good things. And we did set our goals to be very balanced. Overall Uber for the center to start having impact across the state, as well as create this, this LHS community, which is in part why we did start our summit 2 years ago as a conference. And so, and then beyond that, it's the typical academic pieces. And then we have something specific for each of the health systems that we work with. And we have done that directly with the chief academic officer. That has been sort of our primary way of doing it, but have tried as much as possible to socialize as we go. We do have an external advisory board, and those are thought leaders more broadly with expertise in learning health systems. And then we have an internal advisory board, but it's like, some folks from the medical school or the broader university, some folks from various health systems. And so it's not quite structured in a way that would help us in making the business case or having the right discussion with an individual health system. I think we tried really hard to tailor to what will be meaningful and will catch the eye of the folks that we are working with.
Okay, maybe one just very quick follow-up and then we can get to the online question. But so with the goal setting with the health systems, how frequently does that occur? I mean, I think some of our experience here is that, well, we have a huge health system, of course, but they sometimes change. It's different by unit and they change frequently. So how do you kind of match the timelines of the health systems? How frequently does that happen?
We've tried to, yes, it's about annual. And there is readjustment sometimes along the way, but it's about annual. Yeah. And what we try to do is, as annual planning occurs, or if there is more frequent, like with our evidence-based care program, we try to match up with them, that type of thing. Yeah.
We have a question from the online community.
Yes.
You gave a few examples of quick turnaround data sets to researchers.
Yep.
What does the process of clarifying data set requirements look like?
Oh, yeah.
We often find that even just that step can be really time consuming.
Yeah. The person who asked that question is right. What we try to do is we have a series of up to 3, but if we can, we'll do it in 2 sessions where we go through the data requirements. We try to, as much as possible, get folks to write it on paper, right? And really try to get it as solid as possible. And then we will meet with them and we try to bring the right subject matter experts, both from our perspective and have them bring the right folks. So usually we can define it within 2 to 3 sessions. And sometimes it's much more straightforward. And we will be honest, right? So sometimes the data that's needed is unstructured data, right? And or it's only available in unstructured data, and pulling it out, say using NLP, is not going to be that easy. Or they're asking for data that has missingness and not good quality. So we do have those discussions too. Or we don't have it mapped. We will also be very transparent in that. We've done a lot of work to, have our data catalog really well laid out. We've actually integrated that into a robust thing called Calibra, which is a data governance and data management tool. But
Okay, I'm going to ask the last and related question. You had 1 or 2 slides about democratizing data access, and I especially liked your diagram, which eliminated the data management step from studies. Where are you in terms of end user access to data like Atlas or Leaf? Training people to do that, interaction with your data people, because that's another skill that a lot of people don't have. Maybe you can summarize briefly in the last minute of your talk.
Yeah, Titus, it's a great question. We've not democratized that. That would be great. And maybe that's something we could look at in the future. We leverage for data access, we use what CTSI has set up. So we've really, I think, benefited from that, right? So we have a secure data enclave. They're able to provision for a project team, able to provide the computational resources. So we've really benefited from that a ton. So I feel very fortunate to have that in place.
All righty, well, let's thank Genevieve for a great talk and QA session.